All right, none of that was true. Certainly not a bright mind. Well, on behalf of the IU Simon Comprehensive Cancer Center, I'd like to thank HealthTree for having this roundtable in Indianapolis. As you all can tell by the gigantic signs on the side of the Marriott, that we are rolling into May, which is Indy 500 month. So that will be exciting. And just to clarify with Greg, I am still a Bills fan, although I will root for the Colts when they're not playing the Bills. We really do have a wonderful faculty here today. Dr. Suvana Sanka from IU, Dr. Callender is coming to us from the University of Wisconsin, Dr. Cole is coming to us from Michigan State. Although he is a University of Michigan graduate, I did see that. And Dr. Avish is coming to us from Washington University. So it'll be quite wonderful talks today. And I hope everybody learns stuff. I'm going to talk about clonal heterogeneity, defeating the swarm in myeloma, and I'm not going to use the word genomics once. So I'm going to let Dr. Callender explain the genomics part. I'm going to explain why clonal heterogeneity. What is that? Why do we care? Why is that important for us to understand? So, cancer is, cancer is a clonal disease. So what happens when cancer starts is that a normal cell gets zapped by something, radiation, an accident, a genetic accident, and it becomes cancerous. And then it starts to divide, and it becomes more and more and more. And so this is what cancer does. And so if all the clones are the same, they're all identical, they've all grown from the same beginning, then if we treat that clone and we find the magic bullet, we can actually kill them all. And that would be great, because one treatment wipes out the entire cancer. Unfortunately, that's not what happens in myeloma. And my titles are all in black, I don't know why. But anyway, so myeloma is actually a swarm of many related but different clones. And this is what we call clonal heterogeneity. Heterogeneity means different. So what happens is that a cell, a normal cell, they're called plasma cells, for some reason gets some kind of bad hit and turns cancerous. And it divides, just like a normal cancer. But in the process of dividing, it starts to mutate. And then all of a sudden, there's another related clone or subclone that is mutated. So it's not the same as the original bad guy, but it's related. But it's part of that swarm that's evolving. And then over time, those develop another mutation. And they change very slightly, and they become part of the myeloma swarm, and so forth, and so forth. So over the time that myeloma develops, it mutates, and it's not one thing, but it's a swarm of different myelomas. They're all related to each other, but they are different. And what does that mean? That means that when you treat them, some of them die, but there are subclones or part of that swarm, some of them that are in fact resistant to the chemotherapy, and they grow back. And this is what we call, many of us who treat myeloma say very characteristically, myeloma is a very chemotherapy responsive disease. When you're first diagnosed, people respond very nicely to the chemotherapy, but inevitably people relapse. They get treated, they respond, they relapse again. So this is the first relapse. Then you go ahead and get treated, and you wipe out some other clone. I don't know which color clone I wiped out. I wiped out the purple ones. But the red clones are resistant to that therapy, so they start to grow back. Oops, I'm going in the wrong direction. And then you treat them again, and you wipe out the red clones. But the purple clones are still there, and then the purple clones are actually evolving. They're getting selected for new clones, the yellow clones, and they grow back. And this is the nature of the relapsing mechanism that causes us the real clinical problem in the treatment of myeloma. So how do you tackle that, right? It's not one thing. If it's one thing, one magic bullet might take care of that one thing, right? But it's a swarm of myelomas. It's lots of different myelomas that make up the myeloma. So this is another reason that multiple myeloma is in fact an accurate statement. It is not one cancer, it's lots of little cancers that are related to each other. So how do we deal with that? And this is the strategy, I believe, why we treat myeloma patients the way we do. Okay, so for newly diagnosed myeloma that are chemotherapy sensitive, we typically do a 3-phase treatment. There is an initial phase called induction, a middle phase consolidation, or everybody knows this as the transplant, and then there's a final phase called maintenance. And what I'll do is go through why do we do that. You integrate combination therapy that uses treatments that do not share common resistance mechanisms. So which means that if you treat with A, it doesn't make you resistant to B. So then you treat A, B, and B doesn't make you resistant to C, so you treat A, B, and C. So what does that really look like? Okay, so induction, typically, as many of you know or actually have experience, is really 3 or 4 different chemotherapy agents combined together with the idea that we try to get the best response possible. And what that is you start off with a bunch of different clones, bunch of different myelomas, you treat them with induction, and you kill off most of them. But there are some that are left over, right? These are the guys that will cause the relapse if we do nothing about them. So then we come back and say, all right, we know, even if we can't detect your myeloma in your body, we know that you're very likely to have a few of those chemotherapy-resistant clones left in your body, a few of them that are resistant to the induction. So then we move on to a different therapy. And this is the high-dose chemotherapy followed by stem cell rescue or the transplant piece with the idea that we're trying to wipe out those little clones that are left over. So hopefully what we've done is wiped out almost all of the clones that are left over, if not all of them. But in a lot of patients, there are few tiny amounts of these resistant clones that are hiding out in your bone marrow. So then what do? We do that 3rd phase called maintenance. And the idea for maintenance is to eliminate or control the residual clones. And again, they can be very, very small numbers. And a lot of the movement in that direction, I think, particularly with drugs like thalidomide and lenalidomide and pomalidomide, now we understand that what we are probably doing as part of all that treatment is activating the immune response. And the cool thing about the immune response is that the immune response is not chemotherapy. The immune response kills myelomas differently than chemotherapy. So anything that was actually resistant to chemotherapy is very likely not resistant to your immune system because the immune system kills cells in a different way, and myelomas have not been exposed to that. So the idea for maintenance is really to actually activate your immune system. And now we've taken it even farther with CAR T cells and bispecific antibodies, which you will hear later today, activate the immune system to now go ahead and control or kill off these tumors. And we know that the immune system can be very effective in controlling cancerous clones, especially if there are not a lot of them. And in fact, for the monoclonal gammopathy of unknown significance, which a lot of people have, and we know that about 1 to 2% of patients with MGUS, people with MGUS will actually convert to myeloma. The other 98 to 99% don't. Why is that? It's probably their immune system, or their immune system is playing a role in keeping those clones under control. So the immune system really, there was a hint that the immune system was very important in controlling myeloma. Our maintenance data suggests that it's very important in controlling myeloma, and the new studies in CAR T cells and bispecifics very clearly shows that the immune system does a great job, if it's activated in the right way, in controlling the immune system. So that's the way that's how I explain to my patients why we treat myeloma in these three phases: the induction phase, the maintenance, the consolidation phase, and the maintenance phase. And we do it to wipe out as much of the swarm as we can with different therapies that are, again, are not cross-resistant. So just as one slide about what do you do about people that have actually gotten a lot of chemotherapy in the past and you're dealing with chemotherapy-resistant disease. And this is the area that our lab studies, and trying to understand why, if you have these cells and you treat them, they don't respond to chemotherapy. So a lot of our research is trying to understand how myeloma cells adapt. They don't start off being resistant to chemotherapy, the vast majority of patients, but how do they adapt in the face of a constant amount of treatment? How do they adapt and become resistant? Because if we could figure out the molecular mechanisms for that, we could target those and make those resistant myeloma cells not resistant. And again, I think a major step forward is, again, immunotherapy now kills myeloma cells in a way that they've not seen before. They're not resistant. I think what we will discover is that patients will relapse from that also, since myeloma is pretty damn smart or tricky or devious. And what are the resistance mechanisms that are involved in preventing the myeloma cells from getting killed by the immune system? So this is just a summary, a lot of words. Clonal heterogeneity, really, that we worry about that because it is the basis, I think, for a lot of the treatment resistance that we see in patients. That for chemotherapy-sensitive disease, the idea is to integrate a bunch of different therapies that aren't resistant to, don't cause resistance to each other, to eradicate as many of these clones as possible. The immune system is going to be an important piece of that. And then the research question really is, why do chemotherapy-resistant myelomas, why are they myeloma, and why are they resistant, and can we target that?